Yes, so welcome everybody to our Zoom meeting here, to our Fireside Chat. Fireside Chat means that we want to have a conversation in a constructive and positive way. Everybody knows on TV that sometimes you have discussions that are meant to heat a situation and blow something up. We don't want that. We want to have the opposite. We want to have a constructive discussion. So that's why we choose the name Fireside Chat. The topic here is an update. So we will provide you, or May is going to provide you with an update on the global HIV data in preparation of the IAC, the International AIDS Conference in Munich. Everybody here in the room knows that the conference will start next week, and we are really looking forward to it. And we are, of course, looking forward to the new data that comes out from UNAIDS. You all know that UNAIDS is gathering the data, and the data that we have on HIV shows us the developments of the HIV pandemic. Basically, every country has its own HIV pandemic. And at least in Europe, it is like that. And then you have broader region where it's more or less the same. But based on the data that we have, we know exactly in what subgroup there's developments and changes in the HIV pandemic. So that's why this information is so very important for everyone who works on HIV, everyone who establishes programs based on the data like the Global Fund or PEPFAR, because based on that data, on that specific data, we know in what direction we should respond to in order to stop the pandemic. So that's therefore this event and this data is quite important for all of us. And yeah, we look forward to hear about the current trends, about the developments. For the time being, we know that we have 39 million people living with HIV globally. There are 9.2 million people without access to HIV treatment. Without access means that those people are going to die, or very likely going to die, if we don't manage to put them on treatment. Those people will transmit the HIV virus because HIV treatment is prevention. We know that from since 15 years now, and we have one person dying each minute on HIV. So while I'm speaking here, already 4 people passed away. So I thank everyone that is here and that is involved in that session. And of course, because I'm nervous, I forgot to mention my name. My name is Peter Wiesner. I work for Action Against AIDS Germany. I moderate here the session together with my colleague Sasha. Sasha is from the Deutsche AIDS Hilfe. So without further ado, I give the floor now to Sasha to talk a little bit about, very briefly, about the housekeeping rules, and then we start with a brief presentation on the new data. Thanks. Over to you, Sasha.
Thank you, Peter. As Peter said, I'm working for the Deutsche AIDS Hilfe. I'm here responsible for the international projects. I'm happy to see all of you right after the UNAIDS PCB and before the AIDS conference in Munich. And before we go deeper into discussion, I would like to tell you a couple of housekeeping rules. First of all, this conversation will be recorded, and we will share recording with all of you, and we will also post it online. The seminar, the conversation today is in 2 languages, English and German. And if you need translation, if the language you are currently listening to you do not understand, so please go down and search for translation sign and choose channel either English or German. I would love to thank our translators Marvin Meyer and Gesina Liebknecht, who are today in this room and who are translating this conversation today, and to all the speakers. And I will remind it again before each presentation. I want to remind, please do make breaks. Breathe in and out so that translations have chance to finish the sentence before starting a new one. So speak slowly and clear. Thank you very much. And we are looking forward for this very exciting discussion with you today. And I would also start with introducing our speakers for today's floor. We have Mary May, who is a director of the Data for Impact team at UNAIDS. Good morning, Mary. We have Dr. George Kiepels, German, who is working for the German Bundestag, member of the Subcommittee on Global Health. Guten Morgen, Dr. Kiepels. And we have Cedric Mininahatzwe, who is a global advocacy manager of the global network of people living with HIV, GNP+. Welcome, everybody, and let's start. I would like to give floor now as a first speaker to Mary. Mary, please, the floor is yours.
Thanks so much, and thanks for inviting me to have this fireside chat. I hope it's not too hot in the room there as it is throughout Europe right now, but it will feel like a fireside chat. The report that we'll be releasing on Monday next week, the July 22nd, Monday, July 22nd, the title of it is The Urgency of Now, the AIDS Response at a Crossroads. And we're really trying to focus on how do we pivot that HIV response based on the data, like understanding of where we are just now. And so in the conversation that I'll take you through some of the data, but it's really about a message about how do we make sure that not only leaders, but also communities and program managers and funders, donors are all kind of moving in the same direction with the HIV response. And before I start, though, I really want, and before I present data, I want to make an emphasis that when I present data, I recognize fully that these are just numbers and they're actually representing people's lives. And I'm trying to show with the utmost respect what we can learn from the data, but it is really describing people's lives. And I just want to acknowledge that before I present. I think one of the questions that people ask is, how does UNAIDS have all this data? And it's really important to say that we get this data because countries submit that data to us. There's a UN political declaration that says UNAIDS needs to report on this, and countries will send that data. But much more importantly than any UN declaration, it's making sure that the countries are looking at their data and understanding that data. And so we really try to support countries to pull the data together on HIV. And then we take that data and publish it in reports and use that data to help with advocacy and programming. But let's start with some of the data that we see. And so the number of new infections is about 1.3 million in the year 2023. And so what's important to recognize is that there's a continued decline in the number of new infections, a 39% decline from where we were in 2010. And most of that is driven by what we're seeing in Eastern Southern Africa, so the region most heavily hit by the HIV epidemic, where we've seen a 59% decline, so very strong decline in that region. But it's still not fast enough to reach the targets that were set globally. And those targets were set to reach certain milestones by 2025. And if we reach those milestones, then we predict that by 2030, we'll be at a point where we can say that HIV will no longer be a public health threat because it will be having reduced so far. But we need to be careful because we're missing those targets. And so the report very clearly says that we have not met those targets. We're not likely to by 2025 at this point. The report also talks about the people currently living with HIV, and that's critical. We have 39.9 million people living with HIV as of 2023, end of 2023. And one of the new pieces of data that's coming out in this report is looking at projections of where we'll be in 2030 and in 2050 in terms of the number of people living with HIV. And so one scenario looks like at whether we meet those targets for 2025, and another scenario looks at if we just keep at our current level of progress. And we estimate that somewhere between 29 and 46 million people will be living with HIV in 2050. And so for colleagues who are thinking about where do we stand with our program, we need to recognize that even though we talk about the end of AIDS, we're really talking about the need for services for people living with HIV that will be needed up until 2050. Millions of people living with HIV up until 2050. And that means we need to have the systems and the services in place to provide to those people. And that's just a really critical way to think about it, because I think some people hear end of AIDS and they think, oh yes, we don't need to do any work, we don't need to provide any more funding after 2030, but that's not the case. We also need to be very careful as we talk about this kind of pivot of what will change going forward. We know that the efforts that have happened so far to get us to 2023, where we are now, 2024, excuse me, will be different going forward. We'll need to be thinking differently. We'll need to make sure we're integrating our HIV services more closely in with other health services and other social services. But as we do that, we can't lose some of the amazing progress that the HIV response has achieved in terms of the innovations. And thinking about, community-led monitoring, community-led services that are provided, and I'm hoping Cedric will talk clearly to this, but we've seen amazing innovation from the HIV response in making sure that the communities that are most affected, the key populations most affected by HIV, are providing those services, and that's what's allowed us to make progress. And so those innovations, as we integrate and sustain our response, we can't lose those. We need to be thinking about that clearly for those 39.9 million people living with HIV. The last second to last data point that I want to touch on is on AIDS deaths. And Peter, you said it very well, that we're talking about people who've lost their lives due to HIV or due to AIDS. In a day when we know how to solve that, how to keep people alive, and yet we're losing them to AIDS-related deaths, 630,000 still in 2023. That should be zero. So that's a stark reminder of what we still need to do. A lot of that has to do with people showing up late to get tested and then started on treatment. So making sure that the services are accessible so that they won't show up late. They'll get those services, get on treatment, and be able to live a healthy life. What's impressive is how many people are on treatment right now. So in end of 2023, we estimate over 30 million people out of those 39.9 are currently receiving treatment. I think, 15 years ago or 10 years ago even, we just didn't think that was possible. We have a target of 34 million people by 2025. We could potentially reach that, and that's great news. So 72% of all people living with HIV are receiving treatment. 77% are receiving treatment, and 72% of those people have a suppressed viral load. And that's so important for allowing people to live healthy lives, being less concerned about transmission. So it's just a really important marker of the success. And so that's been fantastic. We're grateful to see that. But there's some regions and some populations where we're not seeing that scale up of treatment fast enough. So if we look at regions, so Eastern Europe and Central Asia, as well as Middle East and North Africa, only have about 50% of the population living with HIV on treatment. Again, probably due to people not feeling comfortable to access services. There's some sort of societal or structural barrier that keeps them back from receiving services. So that's a really important piece to be looking at. What's stopping that? And one other piece that I want to talk about is the key populations. And we talk about men who have sex with men, sex workers, people who inject drugs, transgender persons, as well as prisoners as kind of key populations that we need to be watching carefully to make sure that they have access to the services. one of the analyses that we quote in the study is looking at what the proportion of all new infections are that took place among key populations. And we see that increasing over time. So going from 45% to 55% in 2023, that increasing proportion of infections that are among key populations means we need to step up the services for those populations. The report also focuses a lot on what we call the 10-10-10 target. So making sure that the human rights are in place, that the stigma is reduced, that gender inequalities are reduced to allow people to get access to those services. We see data from a stigma index. I think Cedric's part of that analysis. It looks at people who are living with HIV reporting on what their experience is with services. And we see that about 25% of people living with HIV experience discrimination due to their HIV status at some sort of healthcare facility. And as we talk about integration, that's something we need to focus on. We can't allow that stigma to happen and to push people away from services. The other thing to note is that 34% of people who experienced that stigma then went on to drop off of treatment at some point in time. So there's this direct correlation to that stigma and the effectiveness of those services that are provided.
Mary, we need to stop you here and we will have more questions to you. Thank you very much for this brief update on the data and especially for mentioning barriers for key populations to reach the services, the existing services. Peter has some questions to you.
Yes, we have now about 4 minutes for you. So this first input from you was, of course, instead of PowerPoint, this was a general information that we need all to have a common discussion based on that. So the next, and we stop now with the question and answer thing. So we have basically four minutes for my questions that I raised to you now. First of all, of course, from my side as well, thanks so much for the input that you provided. So what are, and you talked about barriers, you talked about difficult countries, as far as I understood. What are the challenges ahead to the global HIV response? So this would be the first question. And based on that, what are the key messages for politicians and for NGOs? So, challenges, key messages, and then maybe you find one word, because we work a lot. We worked a lot in the past on the situation of HIV in Russia and in Eastern Europe. So maybe one sentence about what do we know about the HIV pandemic in Russia? Is Russia very friendly to share its data, or how do you get the data? And you have only 4 minutes. I apologize here, but we have other speakers as well. So please, the floor is yours. Thanks, Mary.
Thanks.
Please,
Yeah.
sorry, please remember to speak slowly so the translator can catch up to you. Thank you so much.
Thank you. Yeah, so I think probably the biggest challenge we have going forward is thinking about how we pivot that response to the HIV epidemic and make sure that we're really pushing down on those barriers. And so I gave you some of the data that we're releasing on the barriers. And one of the surprising findings we have coming out of the report is that there's more new infections happening outside of sub-Saharan Africa now than inside sub-Saharan Africa. And what you see there is that in the epidemics that are primarily among key populations, we're not getting the traction we need in terms of prevention and treatment. And so, the challenges will be really about those 10-10-10s, pushing the human rights, pushing down on stigma, and making sure that we have gender equality as well. So, those are our big challenges going forward. As far as messages, we're trying to get, and I love the way you frame that, Peter. It's not just about to leaders. The messages are to communities as well. Communities, program managers, activists, making sure everyone's heading in the same direction. And so our key messages are really about the urgency of now, saying right now we need to focus on where we're going in terms of prevention, especially because we're seeing that outside of sub-Saharan Africa, that prevention, the new infections are not going down. And so making sure that the leaders are really focusing on how do we improve the prevention services? How do we, and then we step back, take the logic back a minute and say, okay, if we need to have access to services, how do we make sure that decriminalization is happening? How do we make sure that the people living with HIV that are most at risk have access to those services? The second thing that we're really pushing is making sure that we have equitable access to medicines. And so that's something my boss speaks about a lot. And you know, we can talk about it in Western Europe, it's one thing, but when we talk about it in low and middle income countries or even middle income countries where they might not get access to those medicines, we'll have major issues with actually seeing those decline in new infections if people can't get access to those innovations. Probably the last message would be around, you know, we need to think about the fact that funding is shrinking, and we need to recognize in that space of shrinking funding, how do we make sure that we are being as efficient and effective as possible as we go through this integration process. So if you ask me about Russia, you know, we've worked well with Russia in the past, having good discussions about the data there and how it works. In the past few years, we have not had much engagement from Russia. As a result, to produce our estimates, we search for their data that gets published online. We put it into a model. We understand then what the trends are. About the trends, though, what we see is that in the last 2 or 3 years, the case reports in Russia have started declining. We hope that means that there is fewer new infections, but one of the challenges with case detection is that it's often off. If a person is hesitant to go get services, it doesn't mean they will go in and get tested. And so we don't know what that means. That's why we use models to understand the number of new infections instead of new diagnoses. So what you'll see in our estimates from this year is a bit of a flattening of that trend of people living with HIV. The new infections in Eastern Europe are still increasing, but it's not as strong as we had thought previously. The other thing to recognize is that we don't publish those Russian results because we haven't had a proper engagement with the country in order to say clearly what we think the situation is. But they're about 80% of the Eastern Europe results. And we see in Eastern Europe and Central Asia, I should say, we see a 20% increase in new infections in that region.
Okay, thanks so much. I gave you a little bit more than 4 minutes, but I think this was super interesting, especially on Russia. You mentioned human rights-based approaches. Everybody knows how Russians love the word human rights. So there's of course a problem here. We do not touch this now, but there's an issue that is a problem, of course. And with these words, thanks to you, I hand over to my colleague, Sasha here.
Yeah, thank you, Mary, for this interesting data report update review. And I would love to ask Cedric, as a representative of GNP Plus, of the global network of people living with HIV, could you please explain the value of this UNAIDS data for program planning, particularly for key populations and for the community-led response? And additionally, in some countries, there are tendency to deny the existence of certain key populations. From your point of view, from the community point of view, are there particular areas where data is still missing?
And Cedric, you have 5 minutes. Please stick to this 5 minutes if possible. Thank you.
Peter is very strict.
I'm German.
Very German.
Yeah, thanks, Peter. Thanks, Sasha. I will stick to 5 minutes. Maybe let me start also by thanking Mary. I think this is I always love to listen to Mary because data is really important. And I have to say, where we are today in the HIV response is because we have been guided by the data. The success that we see today is because we've been following what data is telling us, and the response has been following the data. But I have to say, I think we've reached a point where we don't want to listen to the data, not because we don't accept them, but because it reached a point where we need more political leadership and dimension. I think I will come to that, but I feel like first of all, let's recognize that data-driven policy and programming has been the key element for where we are today in the response. Now, the question is, we have 9 million people who are not on treatment. And we know from fact that this is not a problem of lacking treatment. Treatment is available, but 9 million people are not taking those treatment. The question is why? And I think this is where we need to start to thinking, why we have people who are not taking treatment, while we do know that we have treatment and people know that this is a life-saving treatment. The answer is, I think, where I started is because we are having, first of all, policies or regulations that are creating environment that prevent people to go for testing and for treatment. And secondly, because of the stigma and discrimination that is pushing people away from services, people don't come for treatment. I think we have recently the WHO report mentioning that there's a 10% of people who have resistant and manifesting resistance to treatment. So we can say, yes, the resistance may be probably for, I'm not a physician, but I think it may be natural for the body not to accept the treatment. But we also know that there are people who don't take treatment because of stigma and discrimination as well. And there are people who not take treatment because they fear about criminalization. So this is also another fact that shows that we do not need to the data we have tell us what need to be done, but we are somehow ignoring it. And I will come also to the, as Mary mentioned, we have the global report on stigma index is mentioning people, 8% of people living HIV manifest internalized stigma. And this shows that, you know, I do know that I'm HIV positive, and the fear of accessing, you know, visiting the service center because people will see me because there's stigma and discrimination around that, and people start leaving the service access, and this is how, not only because of the natural, maybe because of not the body to accept the treatment, but people are also leaving the health services because of stigma and discrimination. And most of the country, I cannot remember the percentage. We know that in many regulations, we have provisions and restrictive measures for HIV transmission. And we know that many cases, people are being prosecuted because of allegations related to HIV transmission. And we know for a fact that this type of restrictions prevent people from accessing to treatment. We also know, not only because of HIV transmission, based on the people sexuality and some also on gender-related issues, there's a lot of stigma and discrimination around services. So the 9 million people that are not treatment, for me, we have to agree this is not because they lack treatment. It's because they don't want to go to take treatment because of the structural barriers, the 10-10-10 that Mehi was mentioning. So now we know where is the problem, and we know that what can be done. I think as I started, there's a political will, a political decision that need to be taken in terms of making sure the environment in which people need to access the test and treatment is more favorable, and people are not fear of being prosecuted or being discriminated at the health center. I will stop there. I think that's 5 minutes exactly.
Thank you very much, Cedric. Thank you so much for talking about existence of prevention and treatment nowadays, but also mentioning the accessibility of this and why people still do not go to take their medicine, and the importance of the political will in HIV prevention field. So I'm really happy that we have a representative of a German Bundestag here with us. Maybe he can respond to it. And Dr. Kiepers will talk in German. So I will ask everybody, all of you who is English speaking, switch to the English channel so that you can understand his speech. And Dr. Kiepers, can you hear me? You need to switch on your microphone. Once again, it's still off. Es ist immer noch aus. Soll ich es anmachen? Genau.
Jetzt müsste es, ja.
Yeah, wonderful. Thanks so much, Dr. Kippers, for being with us. You are a member of the subcommittee of Global Health in the Deutsche Bundestag, and we are really happy that you are with us here. So thanks so much. You listened to the data, you listened to Cedric, what he had to say, and
Moment, ich übersetze ganz kurz, weil wir müssen das auf Deutsch übersetzen. Herr Küppers hat nicht mehr die deutsche Übersetzung. Herr Küppers, vielen Dank, dass Sie da sind. Sie sind Vorsitzender.
Ich verstehe es.
Okay, gut.
Danke. Kein Problem, ich verstehe es.
Okay, so Dr. Kippers, how important is this data that you listened to parliamentarians and policymakers, and especially for you as a member of the subcommittee of Global Health in the Deutsche Bundestag, what challenges do you see for the upcoming years? You have 5 minutes, and then we will come up with the next question. And to the audience, Dr. Kippers needs to go a little bit earlier, so that's why we address the two topics together. Together, Dr. Kippers. So, Dr. Kippers, the floor is yours. 5 minutes, please.
Ja, vielen herzlichen Dank für die Einladung. Vielen Dank für die Gelegenheit, hier die politische Brille aufzusetzen und die aktuellen politischen Geschehnisse jeder kurz zu beschreiben. Ich bin jetzt seit 11 Jahren in der deutschen Politik mit dem Kampf gegen HIV/AIDS beschäftigt, und dieses Thema war in der Anfangsphase, also seit 2013, in allererster Linie im Entwicklungshilfeausschuss verortet. Dort haben wir uns mit den internationalen Institutionen, vor allen Dingen dem GFATM, ausgetauscht und versucht, die deutschen Beiträge im Kampf gegen HIV/AIDS zu leisten. In dieser Zeit war auch die Anteilnahme und auch die Unterstützung ständig wachsend. Jetzt haben wir allerdings die Zeit einer besonderen Herausforderung, nicht nur, dass wir kriegerische Auseinandersetzungen auf vielen Orten dieser Welt haben, die vom Kampf gegen Krankheiten ablenken und auch Mittel binden, sondern wir haben auch eine Überlagerung mit weiteren gesundheitlichen Herausforderungen. Alleine 3 Jahre war die Welt im Bann der Corona-Pandemie, und es sind eine Reihe von sonstigen Aktivitäten durch die Corona-Pandemie massiv behindert und benachteiligt worden. Jetzt stecken wir in einer multipolaren Krise auf diesem Planeten, aber wir dürfen gleichwohl die notwendigen Fortschritte nicht aus dem Auge verlieren. Und gerade in den Zeiten, in denen die finanziellen Mittel knapper sind oder zwischen verschiedenen Akteuren verteilt werden, ist es extrem wichtig, zielgerichtet arbeiten zu können. Zielgerichtet arbeiten zu können, das heißt tatsächlich die Anknüpfungspunkte zu identifizieren, wo die Maßnahmen besonders wirkungsvoll sind, wo wir besonders viele Menschen erreichen können, erfolgreich erreichen können und auch mit den eingesetzten Mitteln, also den Medikamenten, aber auch der Diagnostik oder eben auch der Prävention, eine besonders hohe Effizienz erreichen. Die Entwicklungspolitik im Allgemeinen war in der Vergangenheit immer motiviert aus der humanitären Einstellung und natürlich aus der internationalen Solidarität. Das alleine ist jetzt eben nicht mehr ausreichend, sondern die Arbeit muss sich auch immer an der Effizienz messen lassen. Ich glaube, das wird ja auch deutlich über die selbstgesetzten Ziele, die wir uns ursprünglich über die MDGs und jetzt über die SDGs gesetzt haben. Ich glaube, es ist auch für die Arbeit ganz entscheidend, dass eine permanente Kontrolle stattfindet, ob an der richtigen Stelle mit den richtigen Partnern, mit den richtigen Methoden gearbeitet wird. Und deshalb sind wir sehr dankbar, dass wir diese Auswertungen, dass wir diese Analysen jetzt im Rahmen unserer politisieren können, dass wir natürlich auch die Frage aufrufen, ob wir vielleicht weitere Akteure aus der Pharmaindustrie, aus dem Bereich der Medizinprodukte im Hinblick auf Diagnostik, aber natürlich insbesondere auch aus der Politik im Hinblick auf die Stärkung von Gesundheitssystemen mehr Unterstützung auslösen können, beziehungsweise auch Einfluss nehmen müssen, weil vielleicht bestimmte Wege nicht so erfolgreich sind wie andere Wege. Und die allgemeine politische Arbeit, die ja auch eben beschrieben worden ist von Cedric, dass wir gegen Diskriminierung, gegen Stigmatisierung arbeiten müssen, ist jetzt eine zusätzliche Herausforderung. Es ist leider kein Prozess, der ununterbrochen nur in eine gute Richtung läuft, sondern es gibt immer wieder auch Rückschritte. Ich nenne da jetzt mal nur die Gesetzgebung in Uganda, die ja, ich sag mal, in jüngerer Zeit zu einem massiven Rückschritt eben aufgrund der Kriminalisierung geführt hat. Und hier müssen dann auch die diplomatischen Wege beschritten werden. Für Deutschland bin ich sehr glücklich, dass wir uns mit dieser Aufgabe nicht nur im Rahmen der Entwicklungspolitik beschäftigen. Das ist sehr wichtig und das ist auch unser Kernanknüpfungspunkt. Aber durch den Unterausschuss Globale Gesundheit ist es uns möglich, verschiedene Ressorts in dieser Aufgabe zusammenzuführen. Das ist für die deutsche Politik eher ungewöhnlich, weil wir immer die Themen strikt voneinander trennen. Für bestimmte Aufgabenstellungen, eben vor allen Dingen auch die weltweiten Aufgabenstellungen, ist das aber nicht unbedingt erfolgversprechend. Und deshalb ist diese zusammenführende Arbeit des Unterausschusses extrem bedeutend, aber auch extrem erfolgreich. Und wir haben jetzt in den circa 6 Jahren, in denen dieser Unterausschuss arbeitet, so viele Akteure kennengelernt und auch möglicherweise Netzwerke begründet, die die Arbeit noch erfolgreicher werden lassen. Ich würde es vielleicht an dieser Stelle zunächst mal belassen.
Yes, thanks so much, Dr. Kibus, for first of all, I mean, for me, it was interesting that you work with the data as well, of course, at a political level, and this is good. That means the data is useful for you too. I cannot go here into the details. I hand it over to my colleague because we're a little bit short of time to raise a second question. And to those who write into the chat, I think we are not able from here to take these questions on, but we are copying them and then we share it with everyone so that there's a chance to get back to those questions later. Thanks so much, and over to you, Sasha.
Yes, Dr. Kibus, also thank you very much from my side for your engagement and for taking data seriously. And right now there are budget negotiations for the upcoming years taking place, and we hear of and we are hearing about cuts in individual budgets in public health in general, but also in HIV/AIDS prevention and response. And Germany, on the other hand, is perceived by many as a global health champion. And we also know that Germany raised her input to the UNAIDS by 2 million euro, which is a great news, but still it is not enough to cover all the lacks in the budget. So my question is, what responsibility do German politicians have, and how do they fulfill this responsibility? And what support maybe do you need from us as a civil society to fulfill these responsibilities? Thank you.
And may I ask you to be brief, maybe 4 minutes if possible, and my apologies for being the bad guy here.
Selbstverständlich gerne. Ich glaube, ich kann es sehr komprimiert ausdrücken. Ja, wir kämpfen momentan um die finanziellen Mittel und ich glaube, der Kampf ist dann erfolgreich, wenn man die Effizienz der eingesetzten Mittel begründen kann. Das ist das A und O. Es geht also nicht um eine generelle Vergrößerung der Budgetmittel, wie das in der Vergangenheit gut möglich war, sondern wir müssen zielgerichtet die Mittel ins Verhältnis zu dem vermutlichen Erfolg setzen. Und dann sind auch die Verhandlungen im Haushaltsausschuss erfolgversprechend. Natürlich muss uns auch klar sein, dass wenn wir jetzt die Finanzierung drastisch kürzen, nicht nur der Fortschritt geringer wird, sondern im Zweifelsfall wir zurückfallen. Das heißt also im Grunde genommen, die erreichten Fortschritte auch noch zerstört werden. Und das kann absolut nicht im Interesse unserer Weltgemeinschaft sein. Deutschland hat in der Vergangenheit da immer eine Vorbildfunktion wahrgenommen. Das hat viele dann motiviert, es Deutschland gleich zu tun. Diese Symbolik in dieser Situation, dass wenn Deutschland eine Thematik unterstützt, es auf jeden Fall eine gute Sache ist, sollten wir auch für die Zukunft weiter nutzen. Wir werden uns in den Verhandlungen noch mal ganz intensiv setzen. Aber zum Schluss, auch da leisten die Fakten, die Informationen, die Analysen einen sehr, sehr wertvollen Beitrag. Vielen Dank.
Vielen Dank. Thank you very much, Dr. Kiepers, and thank you again for mentioning sustainability and how important it is to keep what we have reached and built up throughout all those years. Now I will ask everybody who is in the German channel switch back to the English channel, because we will continue speaking in English. Dr. Kiepers, do you need to leave now?
Yes, indeed.
Okay, thank you very much for being with us and for your input in this conversation today.
Vielen lieben Dank.
So now please switch back to the English channel, and we will continue talking about policy response to the provided data, its urgency, and also touching a bit the topic of the upcoming AIDS conference in Munich. Peter?
So my next question goes to Mary, and I have to speak slowly. So my next question goes to Mary. And so what does UNAIDS need in order to fulfill its work at country level and, of course, the core budget? We did hear about structural barriers. We did hear about the anti-rights movement. We heard the word Uganda, and everybody knows at the moment probably what Uganda stands for. So the anti-LGBTIQ rights that are established there that drive people underground away from HIV services, as Cedric pointed out. We speak as well about Ghana and Kenya, where those restricted flows are currently discussed. So my question to you is, what does UNAIDS need, and how can UNAIDS contribute to that situation? So maybe you come up with one example. You have about 6 minutes, not 8. So the floor is yours, and thanks for being with us, Mary.
Thanks, and maybe I can switch your question in a different order, just to say first, what can UNAIDS bring to it, and then what does UNAIDS need in order to do that? And if I think about what is UNAIDS' kind of unique contribution in the HIV response, it's about convening first. That's 3 areas. First, about convening and making sure that we have people from communities in all of our discussions about the HIV response, whether it's about deciding what will go into a global fund grant or deciding what we're going to ask our own country for. If you're sitting in a country, that's critical to have community voices there. And so that's one piece that UNAIDS often brings to the table that wouldn't happen without us. In addition, we pull together all of the UN partners so that we don't have ILO talking one story and WHO telling another story. We try to pull that all together. So that convening piece is really important contribution that UNAIDS provides. The second is what we've just been talking about, is the data. And I appreciated what Cedric was saying, is the data has really helped us get to where we're at. And by making sure countries have that data, that information to drive their response, and then pulling that together at the global level to drive where we're going with the response, is the second big contribution that UNAIDS has. So the convening, the data. The third piece is what we were just talking about as well, is watching the policy and the human rights and keeping track of that. And, starting at the country level, where we have country officers who are watching what's happening in Uganda and Ghana and Kenya, to alert people to say, hey, this is what's coming up in the discussions in the parliament. And this is what we need to do to make sure that those harmful laws don't get passed. And so that happens at the country level, at the regional level, and at the global level. And so those 3 pieces is what UNAIDS really brings to the table. What we need, though, is some more sustainable funding levels, and not it's more predictable funding levels is probably more accurate. It's very hard to run an organization, as many probably on this call know, if you don't know what's going to happen in the coming year. And so we're looking carefully to parliamentarians as they have to negotiate a very difficult situation based on the political rights pushback against human rights. Having to negotiate that is difficult, and we recognize that. But what UNAIDS is requiring right now is more predictable funding. We thank Germany for the contributions they've made so far. And Germany is a critical, as you say, a champion of public health, and that's really important to us. Thanks.
Thank you very much, Mary. I have a actually very short question to you, Cedric. From your perspective as a representative of the community, what is needed to better integrate communities in the HIV/AIDS response?
Funding.
Funding as well. As a topic.
Yeah, but I mean, I say it like that, it would sound like easy. I mean, do I have like 3 minutes just to check?
No, you have 5 minutes.
All right, thanks.
You have 45 minutes.
Yeah, I think that the HIV response in general has been one of the leading, I would say, movements which really respected the engagement of communities. If you think about the Denver Principles from the 1983 and the JIPA, I think 2006, the greater engagement of people living with HIV. This has been crucial in terms of working with the community until where we are today. And I think understanding the principle of working with the community has also been crucial in terms of reaching the far to reach population from the community, but also really trying to bring community close to the service. The merits of community engagement is really we don't need to discuss that anymore. But I think one important point is there's a lot of issues related to funding. I started as a funding. It's a problem because not only access to funding for community-led network is more, I would say, it doesn't come that easier. Whilst we know that community is needed, we still think that community should work as a voluntary, workforce. So I feel like beyond accepting and recognizing the importance of working with the community, we also need to see what does it take and what kind of investment need to be taken to be taken into consideration to work with the community. I would say, because we are talking about data today, one of the key examples of working community that has been really successful, and we've been talking about this, is the stigma index research. This is a study that is entirely led by community for community and with community in various countries. And this data has been useful at many levels, and I think Mary can confirm that even UNAIDS. So we see that if we closely work with the community and invest community with enough funding, it helps to it's an investment that has a very good return in terms of the response, but also that can help even go further beyond the HIV response. We saw it when COVID hit. Community were there to they stood up and then they were helping, and it's not entirely HIV related, though we community also got so much affected. But because there's a structure that has been there thanks to the HIV response, the structure of community, this has been also helpful. So investing in community, working with the community is not only important for the HIV, and it's not only important for community itself, but it should be part of the health system and the way we respond to the HIV, but to the broader pandemic. There's a question, I think maybe I don't know if we're gonna get time for that. I'm not sure. I don't think I spoke 5 minutes in terms of integration, and I'm very I see it in the chat from Andrea. I hope we can answer to that, but I just want to tell Andrea, the way I see integration, it's a very difficult question, and then it's not gonna be integration is not going to work in countries in a similar way. It's a question that needs to be taken at the country level, but maybe we need to agree on key principles, I would say. Thanks.
Can I add with one other question to you? What is the added value of community-based data? And I mentioned now one example, which is surveillance on treatment interruptions. Everybody knows that countries don't want to report on that because it makes them look bad. We know this from tuberculosis. In India, it happens all the time, those interruptions, because treatment, the supply chains, nothing really works, and they try to hide that. But in terms of HIV treatment, this happens in some countries as well. So what is the added value of community-driven data gathering? Maybe you can be brief here.
Yeah, no, 1 minute. I think there's a lot of value in terms of community data, but I would just give an example of illustration so that we understand why community data should actually be part of the bigger, I would say, should be key in the way we collect data. So when we talk about stigma and discrimination, you can try and understand, for instance, why someone has, is not coming back to the health services center. And if you send someone who is not from the community, I don't think it will be easier to get the right response you want. And because people they're more open if they see their peers working with them. I say there's many things that we can talk about the added value of community data, but if you look in that perspective, community getting to the community, reaching to their peers to get information that help us to program and develop policy that are more effective. Community is really central. Community data is central because community knows community, and community is close to community. Community understands community better than anyone. I will stop there.
Thank you very much, Cedric. And however, it might be obvious for activists and advocates how important community involvement is. we do have to mention it again and again, sadly, and we have to name our community, we have to name our key population. So we have to stay here. Thank you very much for your input. And as a closure of this meeting today, I would like to ask you, what are your expectations from the AIDS conference in Munich? Do you have, I'm sure you have a lot of plans, but what is your main goal? What are your expectations from this conference this year? Cedric.
So we open the wish list now, and you can of course mention the financing and your dreams. Stick it to 1 minute, and then the same question will go to Mary. So what are your wishes?
I'm getting too much excited the more we have a conversation. I think it's an important moment. The AIDS conference is happening at a very important time where I think we're gonna start with talking about sustainability of HIV response. I think next year we're gonna start the development of the global AIDS strategy. In the framework of the sustainability of HIV response as well. Seeing community gathering there, for me, it's an important moment, especially that we have the Living Conference to start getting insight, but also sharing with the community what do we need to look at in these processes, and how can we stand ready to make sure that the gains we have, but also the gap that we're still having, very well taken into consideration in both the sustainability process, but also into the next global AIDS strategy. Thanks.
Thank you very much.
And now the same question to Mary. So Mary, what do you expect
So I think what I'm excited about, and I see it on the agenda already, is a lot more about the TENs, a lot more about the human rights, and that's fantastic. You know, I think that effort to really look into what is keeping people from services, that thus leads to the continuing new infections. And the second thing I think is so important is the location of this conference. Being in Munich, being in a region where we're just not seeing the new infections go down in Western and Central Europe as well. They're kind of sizzling along. There's not a decline. And then being right next to Eastern Europe where we're seeing an increase. Both of those mean, okay, what's going wrong? What haven't we succeeded? And hopefully will lead us into more discussions about the TENs.
Thanks so much. We are almost there. We have 1 minute, so some more sentences from me. I'm not going to summarize now the overall discussion. I think we mentioned some of the really important points. We will make the discussion available after that call. So let me just say thanks to you as the presenters and the speakers. And of course, we talked about the magic of